Yeah.
Good morning, everyone. This is House Healthcare. It is Thursday, April 2nd. And we have in with us this morning, and thank you so much for joining us, Dr. Richard Page, who is the Dean of the College of Medicine. And honestly, in all my years in healthcare committee, I don't think we've ever had anyone in from our medical college. So we thank you so much for coming in.
Well, it's my pleasure. I think I've gotten to be there once or twice. I know I've been on the Senate side as well. But it's my pleasure to be with you.
Yeah, we have this bill around primary care, and we have been sort of delving a little bit deeper into the our system of primary care in the state, in the US, our challenges, our workforce challenges, and just sort of incentivizing or trying to incentivize providers to go into primary care. And it's occurred to me that, we really know very little about medical education. And we also have in later tomorrow, I think, the dean or the program director for the residency, the family medicine residency program. So
right, that's Gordy Powers. Yeah, I saw that you've invited him. I think that's great. How are we doing in terms of time? I've got about maybe 5 minutes. I might be able to kind of bring people up to speed as to who I am and my perspective, the perspective I bring as dean, and also I can give a few comments about the bill. Is it okay if I just lead off with a little bit?
Absolutely, lead off,
right.
And you have as much time as you need.
Great. Well, thank you very much. Again, my name is Richard Page. I'm Dean of the Larner College of Medicine at the University of Vermont. Soon after Marlene Trump, our president, arrived, I was also named Chief Medical Affairs Officer for UVM. And in a lot of ways, that's just codifying what I already do, and that is as a senior leader of UVM and the physician senior leader participating in activities within the university and representing the university as appropriate. I wanted just to emphasize, it gets confusing because right down the hall from me is UVM Medical Center, which is part of the UVM Health system. The university and UVM Health are separate 501c3 organizations. So there was a time when the dean was responsible for the hospital, as well as the activities there, as well as the college. Over the last more than 25 years, those are separate roles, although clearly we're both the largest entities in healthcare in the state, and we work closely together. I'm providing my testimony to you in my role as I mentioned, a practicing cardiologist and working closely with the UVM Health system, but I'm speaking on behalf of the Larner College of Medicine. At the outset, I want to share with you that I believe all of us are absolutely committed to accessible, affordable, high-quality healthcare for every Vermonter. That includes primary care as well as specialized care and hospitalized care. Our citizens deserve the best possible care, and I'm absolutely committed, as I know you all are, to those fundamental principles. Vermonters deserve it. Our role in the college is to help provide doctors who are going to be practicing in the state, and right now we're focusing on primary care. And in addition to education, I do want to mention that we're studying what we're doing. If you think about it, Vermont being the second most rural state, or the most rural state in the country, and the second oldest state in the country, we've got to be able to assess how we're providing care, make sure it's the highest quality, most affordable, accessible care we can possibly provide and study that. And along those lines, I want to mention that we bring in major grants, including that are both often related to care, such as rural addiction through HRSA, but also the Northern New England Clinical and Translational Grant, which is a big grant that we share right now with Maine, as well as the Health Services Research Center and the Northeast Rural Health Research Center. That second Rural Health Research Center is actually led by a relatively recent recruit that we brought over from Maine, bringing money, federal money in for us to provide care and study care here in Vermont. The last time I was with you all, I was actually on behalf with Randy Holcomb, speaking about the importance of the Cancer Center, which I do want to emphasize, even though we have not, with tight budgets, we've heard nothing but support, but have not been able to get financial support. That's okay. I just want you all to recognize that cancer care is critical for primary care, and we are absolutely committed to our patients throughout the state, every one of our 14 counties, being able to access high-level care where they are. We bring them to the medical center only when needed, and then support them. And at the end of the day, in terms of maintaining a workforce that is able to practice at the highest level as a primary care provider anywhere and have job satisfaction, lower burnout, the fact that they are one call away from an academic system that's committed to Vermont is really a high value entity for primary care. Now, I want to share with you a little bit and some statistics around the Vermont workforce. 32% of all physicians in Vermont either were educated at the Larner College of Medicine or were trained in residency at the medical center. And if you look at primary care providers, 38% either were educated in my college or were trained, and some of them or were trained at the UVM Medical Center. In our curriculum from day one, our students see patients, and we integrate our first-year students from the very beginning and throughout into primary care opportunities in developing a primary care pipeline. I should mention we recently recruited a director of rural medicine within the Office of Medical Education, who's specifically going to help us focus on providing a rural healthcare experience to our students. And we're talking about developing a rural track where students come in and are accepted to a track where they specifically are part of a pathway to rural primary care. I want to mention the Area Health Education Center, or AHEC. I'm going to be using the term AHEC for the next minute or two, but this is a grant. We have 3 AHEC centers. The major one is associated with the Larner College of Medicine. These are funded by HRSA and are committed to supporting programs for students, trainees, and practicing primary care providers. I believe Ann Morris has provided testimony to this committee. Dr. Morris is Associate Dean for Primary Care. I have an Associate Dean who specifically focuses on primary care, and she's also our AHEC Director. And through AHEC, we make sure and are committed to our most rural and disadvantaged communities gain exposure and access to healthcare providers. We have an AHEC Scholars Program, and actually 79% of our students are touched by that program sometime during their medical school, and actually 39%, so 2 out of 5 of our students, when they graduate, have a special lanyard that designates them as having been an AHEC scholar with specific experience in and around primary care. We're following this, and those who went through that program have twice the likelihood of of practice going into a permanent practice in primary care.
Would you mind an
AHEC
interruption with a question? Because I think
Yeah.
Leslie has a
Yeah,
question.
thank you, Dr. Page. Leslie Goldman. I'm just clarifying. When we looked at our budget, there was a line that we were asked to support AHEC. And so that was coming out of the general fund. But what I'm hearing you say is that it's all funded by a HRSA grant. So I'm just trying to understand that dynamic.
Great, thank you for allowing me to clarify. It is funded by HRSA, but critically dependent on matching funds from the state and hospitals.
Okay,
As a
thank you.
matter of fact, if we don't get that, we can't draw down the federal dollars. So
Okay,
thank you very much for that clarification. And I'll actually address the AHEC, kind of the line items that frankly, we're delighted have received some support, but actually in part are related to this bill we're discussing today. I do want to mention that we're really proud that 36% of our patients who graduated who matched this last month are going into primary care specialties. That includes a total of 42, with 10 to family medicine, 20 to internal medicine, 10 to pediatrics, and 2 to medicine and peds combined. I should mention that a lot of us consider OB and psychiatry to be primary care specialties as well, and those were also very well represented. Actually, with 9 patients going into OB, and I think about the same number going into psychiatry this year.
Can I just clarify? So
Yeah.
match day, I know, was just last week or whenever it
Yeah.
was. So you're saying that 30, I think you said 36%?
36% of our students.
36% of your graduates, your MDs,
Right, of those matching, yes,
have matched into
primary care.
primary care residency programs somewhere, not necessarily at UVM, but somewhere
Right, no, in general,
in general. Okay, great.
yes, yes.
Thank you.
Um,
Oh, wait, one more question.
yeah.
Sorry.
Doctor, thanks for coming in. How many of those that you're talking about are Vermont young women and young men?
I don't have that number for you. I can tell you generally a quarter of our class is UVM or our Vermont state residents. So I think my bet is it would skew. I can find that number, I suppose, but I don't know that offhand.
Thank you.
You bet. Final thing I'll just say about AHEC, in first of all, one way or another, I don't know if through this committee, the placement grant helping bring doctors into the state was funded again this year. Thank you. Over the last over a period of time, I'm not sure exactly, we have 62 physicians over the last 5 years, actually, who came through associated with AHEC recruitment. The educational loan repayment plan was funded this year, a little bit less than what was requested, but it was funded significantly. The AHEC support grant, which is split among the 3 AHECs, actually was not funded this year. And that really is useful for, my goal is to be having contact with middle, high school students, really developing a pipeline within our state to take care of patients in our state. And the last thing about AHEC I'll mention is there's a line on page 10 of the bill we're discussing today, which removes the sunset of the AHEC Scholars Loan Incentive Program. This, to remind you, this gives in-state tuition to 3rd and 4th year students who then can train anywhere, but they are committed to coming back to Vermont for a year-to-year payback for them to have that received as a scholarship. Otherwise, it's become a loan. And we're really excited about this. The first time I ever spoke with legislators in the state was soon after I arrived, when this was just getting started. And I would love for it, I think it was a 5-year program. we really should not sunset that. And that's in a line in this bill. And one way or another, we should continue that. That's a way for these students to have the opportunity to take away some debt, which helps them choose primary care, frankly, because primary care doesn't pay as well as some other specialties, and for them to be committed to come back to Vermont. So just to summarize, we are committed with you to developing the workforce in primary and specialty care for our state. We're committed to having our primary care physicians want to stay in the state. We're committed to access, affordability, and high quality. And now this in my 8th year, and this is the last job I'm ever going to have. More and more, I like to think of myself as a Vermonter. I'm told I need a few more generations to really have pages be Vermonters, but I'm tremendously grateful for the opportunity to visit with you all and to serve as dean of the single college of medicine in the state. If you like, I can shift. If there are any questions, I'm happy to take them. Otherwise, I can shift to just my perspective on this bill, keeping in mind I'm speaking as a member of the university, dean of the Larner College of Medicine, where I don't control the healthcare system and how it operates locally or statewide.
Let's see if we have any questions. I know I have a couple before we shift to the bill. Okay, no other questions, so I guess I'll go ahead. So I've been thinking a lot lately about sort of the hierarchical structure within medicine. And would you agree that there is? I guess I should ask you that.
Yeah, without knowing exactly what you mean, I can't say anything, but yes, there certainly are hierarchies in terms of the faculty. There are professors, associate professors, assistant professors. I'm not sure which hierarchy you're referring to.
I think I'm more referring to how we've gotten to the point of a hierarchy within various specialties. Would you agree that there are some specialties that have more allure than others?
It depends how you put it. I mean, for me, in some ways, you can put primary care as the highest of all because of the mission and the breadth of their care. If you're referring to payment, and I can't say it's just, but if I'm participating in the hiring of a neurosurgeon versus a primary care doctor, the benchmark is different in what they're paid.
Yep.
Is in a just world, would that be the case? I can't really comment, but it's the way the world is. In terms of hierarchy of how competitive specialties are, there's no question about that. For example, I mentioned neurosurgery, I mentioned orthopedics. Nationwide, and I don't know whether it's related to them being paid more or what, but nationwide, those are very competitive specialties. So for example, if you're not top in your class, you're not even going to get an interview for those. Nationwide, there are opportunities for primary care that are available to anybody in any level of their class. Now, we don't graduate anybody. Every class is going to have a top, most competitive, highest grades and scores and less. And nobody's going to leave our college without being a well-qualified future physician. But to answer your question, if you're specifically going after which is more attractive, there definitely are more competitive specialties than others. Primary care, geriatrics, even infectious disease. Pediatrics has become less competitive. One of the things that I like about the commitment that we're making in educating and providing opportunity and exposure to primary care. And the commitment that we all are talking about is how can we support primary care physicians? We need to make it as doable as possible for those who are called to that specialty. That's why the payback, the scholarship, I don't want someone feeling like I've got $200,000 in loans. I can pay it off faster doing one specialty versus another. But that often plays in people's minds. I will tell you though, as I'm celebrating the matches of our students, knowing that some of them have significant debt, what inspires me is how many of our students choose specialties like peds, like family medicine, and then subsequently specialize in geriatrics. Even though they've got debt, they're in medicine for the right reason and they're following their heart.
How much, the other thing that we've sort of been learning about a little bit is sort of the federal funding of medical education and where federal dollars are invested. So of all the federal funds that Larner College of Medicine would be receiving for various things, how much of those funds are specifically grant funds?
It's almost
specialties
almost entirely grant funds from one way or another. The federal funding, we receive some state funding and we're appreciative of that. That comes from the appropriation that comes to UVM. But the federal funds that we draw down are based in the college, are based almost exclusively on grants that we write. So we'll write for HRSA, we'll write to NIH. Some of these grants and likewise foundation grants as well as federal are around specific programs, often for community outreach and even care. But the majority of our funding, we get $100 million at the Larner College of Medicine in extramural grant support for research. So that's research grants.
I think that's what I was trying to
Yes.
extrapolate a little bit, is of all of your grant funding, like as a total, how much of that federal grant funding is specifically tied to grants that support the medical education and encouraging the workforce within primary care, as opposed to things like research?
Yeah,
Or-
almost all of it's research related. The HRSA grants are kind of a combination, but those are all things we write for. The AHEC is not a huge amount of money by any means. There is a significant amount going to the rural addiction through HRSA. We'll go for any grants that are out there. But most of the grants, the vast majority, are for research grants. The research grants that we're obtaining, though, span the spectrum. We have people studying the individual neuron and capillary relationship of blood flow that will end up having an impact on dementia. But we also have, for example, a grant that is an NIH grant studying how you follow cancer chemotherapy neurologic side effects using an app on your iPhone. That is a beautiful grant for our state because we're able to reach out to the rural community. But the vast majority of what we receive are research grants, and the research grants are vary among primary care and general, but it's usually not, it's not designated exactly the way you're describing. The one area I do want to mention is the federal money that supports residencies. That's, again, I'm not responsible for the residencies, but because residents are employees of the medical center, and as I made clear, we're separate entities, although they're within departments that are shared with the medical center and the college. And those federal funds, they've gone up a little bit, mostly in primary care, which is great in terms of, I don't know whether the committee is familiar with the caps on residency positions. Every hospital is given a certain amount of positions that are federally paid for, and any new positions are what's called over the cap. And we're about 70 positions over the cap, which means there's no federal funding. It's purely the residents are paid by the medical center. I am aware of the fact that our residency is in the process of going from 6 to 7 per year, which means at any one time, instead of having 18, we'll have 21 residents in the residency program. And that is actually over the cap. So that's being funded by the hospital, but is a good thing. And I'm glad they're doing that. And keep in mind that the residents do play a useful role in terms of primary care as well. Residency is almost like an apprentice program in that you're learning at the side and you're doing as you're learning. So that's another place where the pipeline, we're educating the medical students in the college, and then the medical center is training them for them to then go out and practice medicine.
Thank you. I have one last question. This is more of a philosophical question, I think. You had said, you said, of course, primary care doesn't pay as well. And that is a truth. I mean, we know that. I think we've accepted that it's become truth and that we don't question why it's like that. And of course, we know there's dozens and dozens of reasons of how we have gotten to this point, to include like the investments that we make, the education, residencies, and I mean, you just talked about federal grant funding and, you know, where that goes. So as policymakers, which we are, it's actually a little scary to think about, sitting around this table, what can we as the legislature do in our limited sphere to start changing the narrative so that, you know, 20 years from now, the dean won't have to say, well, of course, primary care doesn't pay as well.
Yeah, it's a great philosophical question. And there, you know, a lot of it goes back to doing procedures have been paid at a different level than seeing patients in clinic. Is that right or wrong? We could talk about that forever. We could also talk about the fact it takes 9 years to become a neurosurgeon as opposed to 3 years to become a family medicine doc or a cardiac surgeon, for example. We're not going to change that right now. And one thing that I worry about in this bill is two things I just want to mention in terms of while I think it is well intentioned, we need to be careful about the consequences that might come from it. As I read talk about quality, I want a high quality doctor. How do you define that? It's really not very clear in the bill. And I can tell you that every physician is subject to quality measures already. So we would be adding an extra burden to the physician and their practice if we're not consistent with other quality metrics, because that as a practicing physician, filling out the boxes by definition is taking you away from being face-to-face with the patient. That's one concern. The other concern is, I haven't done all the math, but the cost of this would be significant. And just as a citizen of the state, I'm wondering where it would come from. And that's something for you all and others to work out. But I'm not seeing any whether it's specialist or hospital that is flush with finances right now. And there were, as you all know, as we all know, finances are really tight right now. From my perspective, the key is I'd love, 20 years from now, I'd love a world that simplified these things. But for now, to shift finances from one area to another, I just think we need to understand how we do that and what the ramifications would be. I do really want to emphasize to you the value of having world-class care in Vermont. I've heard it said, can we afford this? We can't afford not to do it, in my mind. I have patients, rich and poor. My wealthier patients can go to Boston, can go to other places, can take off time to be in another state. So it becomes an equity issue for others who don't have that privilege. I would also mention that even if our patients do get to go to another state to get that care, we'll end up paying for it, and potentially at further cost and certainly at further difficulty for the family. And basically, if we're not able to provide world-class care here with the commitment for patients to be able to go back and be at home and live a productive life within our state, then those who won't get care will only come back sicker, and we'd be doing a disservice to the patients in the state. So one of the things that obviously attracted me to be here in the state is basically the world-class care and commitment we have to primary care being as good as anybody else's, and again, affordable, accessible, and high quality. I'm completely there with you, complemented by having a world-class academic medical center and having world-class specialty care when our patients need it.
Can you give concrete or singular example of something that you would consider to be world-class care that if we were not investing in it, we wouldn't have here in Vermont? Can you give us an example of something or procedure or something?
I can give you an example of CAR T therapy, chimeric something therapy. It is an immune type therapy for cancer. And for some cancers, it is state of the art. It will make a decision as to whether someone lives or dies. It costs a significant amount of money. I'm not going to give you the amount. It's eye-popping. It ought to be paid, and actually, if you do it right, it's paid by Medicare. And for the costs of it, CAR T therapy is something that those with privilege can go to Boston for. Those without privilege would not get it and would not have the opportunity to potentially survive from their cancer. We're doing this as an outpatient as much as possible. It started as all inpatient because you have to make the compound specifically for that patient's cancer, then that gets infused back into them. You form these CAR T cells and this immune therapy. It can make the difference between life and death. And that's just one example. I'd love to show you all around what our doctors do. When I say our doctors, because they are dually employed. They're employed by the medical center. They're employed by the college and university. But that's just one example.
Do we know how many of these therapies UVM does? And does Dartmouth do this? I'm assuming
the best person to give that response would be Randy Holcomb, who could give you the numbers. Randy is the cancer center director that I recruited 4 years ago. But that's just one example. But we could give you those numbers, and actually it makes the difference between having nothing and the other thing that I'll mention is, if you don't do CAR T therapy, you go through further courses of chemotherapy, further courses of toxic chemotherapy. The patient often, most of the time, will not survive. The cost of that is baked into the hospital system. You're not to turn patients away, and you're going to give them chemotherapy that's standard of care, which per dose is less, but the overall cost for their care ends up being significant, if not equal.
What was his name? I'm sorry.
Randall Holcomb, Holcomb.
You.
He's a cancer center director. And he's been back and forth typically with me just about every year, Wendy, right? As we've been making the case for cancer center designation. And when I say that, if we have 2 minutes, we're going longer than I think you wanted, but the cancer center designation by the National Cancer Institute, the NIH, will provide better care to Vermont because it provides not just grant money for research, but it elevates the level of care for every Vermonter. And the leverage on that investment, once we get that grant to bring in further support for our clinical service, first and foremost, patients come first, but also for research and education. The other thing I will mention, since we're talking dollars, is economic impact.
That's true.
I mentioned research, and we get about $50 million from the National Institutes of Health, NIH, annually in our college.
I'm sorry.
It's
How much?
estimated, I'm sorry,
How much was that?
50 $50 million annually. Most of that money goes to pay the salaries of faculty, and more than that, the technicians that are working on the research. It's good paying jobs. The estimate is that for every dollar that the NIH brings in, it adds 2.5 to the local economy. Because this is outside money coming in, supporting people working in. So that translates to about $125 million just for our NIH extramural funding. And at the end of the day, I think we can all agree we need more people having good jobs, being supported, more money coming from the outside to shore up the health system in our state. Because as I said at the outset, we're a relatively old state. The demographics are working against us. And we're all committed to providing care that's accessible, affordable, and high quality.
We had Randy Holcomb come and testify.
Okay.
Here.
Yeah, I remember that. Brian, did you want to go?
Yeah, a minute ago, or a few minutes ago, you said something about, you were comparing the chimeric therapy with conventional chemotherapy. And you were saying that the patient who gets the conventional chemotherapy costs a lot of money, and the outcomes aren't always so great. But then there's this other therapy available that we don't always provide. And what did you say the barrier was? Why we wouldn't choose the thing that maybe costs more but works versus something that costs a lot and doesn't work?
Well, yeah, it actually, the barrier was overcome. In partnership with the medical center, the acceptance was that we would and we do provide this care. So that was 2 or 3 years ago now. And it's happening, and we are providing that. That's just one example of how we're able to provide great care for our patients with the expectation that they can go home sooner, be cared for locally as much as possible. But having that here in the state cannot be underemphasized. Those with privilege and wealth can get it in Boston. Those who don't have that and their caregivers can't take off time to move in for a few days in another state, won't receive that. And at the end of the day, we no question, we need to be smart about our finances. We need to provide great care. And that's what we're all wrestling with and how we manage that.
So, Doctor, I'm a little bit confused. You just answered a question about you provided here, and then I think, correct me if I'm wrong, I think you just said, if you got money, you can go to Boston and get it. If you don't, you're not going to get it.
I think what Dr.
No, if we did not provide that, what we're doing is by having a high level of care, and this is just one example of many, where since we are providing this care, that allows for Vermonters to have high quality, equitable care.
Prior to the academic medical center providing CAR T, people had to go to Boston to get it. But now that we're doing it here,
Right.
anyone can receive it here.
Right. Yeah, sorry if I was unclear on that.
Okay, yeah,
Yes,
thank you.
okay.
Is there any other treatment that is currently available that there's barriers in the way of people receiving it here that we could change, like similar to this example of CAR T therapy?
Yeah.
Is there any other emerging technology or therapy or treatment that people aren't able to get in Vermont, that unless they're privileged and they travel out of state?
I wouldn't have all the answers to that. I don't, not that I'm aware of. I will mention that we have cardiac surgery here. We have pediatric specialties here. We have neurosurgery here. If we didn't have an academic center, we would not have those in the state, and we're fortunate to have those things here. So if that's answering your question, there are some things we don't do here. We do not do cardiac transplant here because we don't have enough people in the state to maintain a program like that. And it's not that it's too expensive. Frankly, if you're not doing 20 heart transplants a year, you shouldn't be doing them at all. And so we have some things we do not do here. We do not have pediatric cardiac surgery. We have adult cardiac surgery because we don't have, but we have very good relationships. So there are some things we shouldn't do and we don't do here.
Sorry.
But what we do here is frankly something we can all be proud of, that we're able to provide the level of care that we do. And it's because of, frankly, the partnership of the academic, the College of Medicine and the Academic Medical Center. And again, getting back to primary care, if I were a primary care doctor, I'd want to be able to call UVM Health and get an immediate consult, which we give them, take the patient when we need, support them to give all the care they can locally. It's a betterment of the doctor's practice and the patient.
So when a person, what I'm hearing is that there's some medical practices or procedures or treatments that it doesn't make sense for us to offer them locally because we don't have the scale of need to justify the investment in maintaining the infrastructure for those things. However, we have connections to regional providers that people are referred to.
You got that absolutely right.
All right.
For the quaternary, they say, certain quaternary practices that require so much infrastructure and require the volume. You don't want to go to a pediatric cardiac surgeon who doesn't have enough to do. You want to go to one who did that procedure yesterday and the day before. And that's why those things need to be centralized in some, frankly, larger cities and states than we have. At the same time, there's so much care that we are able to give here that we really can be proud of, and frankly, I believe our citizens deserve.
Leslie.
Thank you again, Dr. Page. I heard that you increased your family medicine slots by one. Is that right? From like 5 to 6? Did I
That's
get
what,
that?
that's what I am told, yes.
Okay, but the new one is not supported by federal funding, is that right?
Right. You may have seen that recently there has been some openings of new residency spots. Basically, once a hospital has its residency spots, the federal government has what's called a cap.
Okay.
And then
If I may
it's-
ask, yeah, if I may ask, I'm sorry, I know we're running out of time.
Yep.
I just wonder what made you decide 1 and not 3, or do you ever think of adding more and more?
Great question. I don't have the answer to that. I'd emphasize, I mentioned that as a step in the right direction. But those are hospital employees. Dr. Powers is going to be talking with you. He's a residency program director, and he can speak to that. To increase the resident complement is when the federal government isn't going to give you any more money, is always a tough decision. I'm actually impressed that our hospital is looking at that and selectively increasing some of those positions because they are bearing the full cost of the salary for that individual.
Okay. So it's really about funding those slots internally rather than
Right.
getting federal support.
Right. And the other thing that limits the number of spots in any place is the number of faculty and clinical opportunities available.
Okay.
I just emphasize that for a state our size, it's pretty impressive that we have as many residency spots, and we even have a medical school,
Right.
which is
That-
something we can be proud of.
I've always been amazed by that. So 6 slots seems to be about the right number is what I'm hearing you say.
Right, it was, and now I'm told we've gone to 7. Or we're
Oh,
going
okay, it's
to
from
7.
6 to 7. Okay,
Yeah,
got it.
right.
Thank you.
Yep.
Thank you. Really valuable information. Really appreciate you joining us this morning. Just thank you very much.
It's a privilege to get to talk with you. Thanks for all you do. I can't imagine sitting in that room working through the decisions you have to make, and thank you for your service.
Thank you. Thank you, Dr.
Thank you.
Page.
Have a great day.
Right. We're gonna do, moving on. S-163, which I know it was days and days ago, so you might have forgotten what it is. We're gonna move on to that. I have it listed as markup and possible vote. I asked, Jen, if you want to come up. I always feel like I'm like setting you up.
The answer was hospital pays
Yes.
were above the.
Setting the stage for legislative council.
Because I was gonna ask.
I had asked them to work on some changes to include physician assistants. So she's gonna walk us through the changes, committee discussion. I did want to mention that the reason I waited for today was because if you recall, the Board of Medical Practice was meeting yesterday. And they did send us some comment, which is posted on our webpage. Very brief, and which sort of reiterates what Dr. Greenberg kind of said, even though he was not representing the board at that time, he was making sort of personal comments. And
Can someone say what it says so that anyone watching knows, or should I go
would you
look?
like me to read it?
Yes.
The board has convened and unanimously approved the following statement. Overall, the board was opposed to transitioning attending coverage for inpatients to advanced practice providers. We have significant concerns about practitioners with less training and experience and the potential safety and quality ramifications. The board did fully support the team approach of care that includes physicians. If the bill were to proceed, we would recommend treating PAs and APRNs similarly. I have a hard time with that word. We would also recommend a minimum level of inpatient hospital experience similar to APRN transition care policy that requires 2,400 hours and 24 months of practice for initial licensure. I would be more than happy to join the committee to further explain the thought process and rationale of this statement.
Thank you.
I'm sorry, I meant to reach out to Devin, who I see is over in Dover. And I realize I'm putting you on the spot, and maybe we can wait till Jen does walkthrough. But if you could maybe sort of reiterate the protocols that, because I think you spoke to that before about like each hospital has certain protocols for this type of thing. And I think that's kind of what they're getting at here. But I'm gonna let you think on that while Jen does a walkthrough.
Hey, good morning, Jen Carby from the Office of Legislative Counsel. So this is S-163, which is currently titled an act relating to the role of advanced practice registered nurses in hospital care, although I've proposed a name change for the bill at the end of the amendment. So this is a strike all amendment, and I've shown in markup what the changes would be. And really, it's just adding physician assistants throughout everywhere. APRNs were added. And so you'll see I've added in a definition of physician assistant as an individual licensed under the applicable licensure chapter in Title 26. For the patient's bill of rights, everywhere it says physician and APRN, I put physician assistant after physician just because it seemed to flow better. So if every patient would have an attending physician, physician assistant, or APRN, and adding that throughout. So attending the right to obtain information from the provider coordinating their care. So adding in physician assistant, right to know the name of the attending, adding in physician assistant, right to receive information necessary to give informed consent, adding in physician assistant, right to know the identity and professional status, and which physician, adding in physician assistant, APRN, or other practitioner is primarily responsible for the patient's care, continuity of care, and right to be informed by the attending physician, physician assistant, or APRN as continuing healthcare requirements following discharge. And then adding in physician assistants as far as who may be subject to disciplinary action for failure to comply with any provision of this section. It could be basis for disciplinary action against a physician under either physician chapter, physician assistant, or APRN, and having a complaint filed with the Board of Medical Practice or OPR. And then for license requirements, this is for hospital license requirements and the minimum standards that a hospital must meet. All patients admitted must be under the care of a physician, adding in physician assistant or APRN. Professional case records compiled for all patients and signed by the attending, and adding in physician assistant. And then for the title, I suggested an act relating to the role of advanced practice providers in hospital care. I don't know if that's an acceptable term, or we could say advanced practice registered nurses and physician assistants if the committee prefers.
The AP, advanced practice practitioners.
Providers.
What I
Okay. Yeah. look,
found while
that
trying to look
seems
this
be
up, but we
okay.
can use whatever term people want, or use the full name of both.
It's confusing. Insurers are called providers sometimes. I was always not really.
I don't think insurers are considered providers.
Yeah.
Sometimes facilities are considered.
They're payers.
Payers. I don't know, I keep using APP lately. That seems to be the new.
Yeah, with APP.
It's not changing statute. It's just changing the title.
That, or maybe I'm dyslexic, but I always am messing up APRN or ARNP and something like that.
AARP, yeah.
All right. So those are the markup changes. I had Jen go ahead and do that in light of our discussion that we had about last week on this and the testimony that we had received. I will say that I've met with, we would be amending the Senate's version, and I have met with the chair of the relevant committee, and as an individual, she's generally in favor, so I don't think that I mean, depending on what her committee, obviously, they can make decisions, but didn't think that there were any concerns with this. Leslie, did you have a question?
Not really for Jen, more for you.
Okay.
Discussion. There's a conflict, it seems, between what the Board of Medicine is saying and what the hospitals are doing. And I'm trying to understand how we think about that conflict.
Yeah, I mean, that was that's the decision before us we heard from the hospitals that this is actually current practice. We heard from the Board of Medical Practice that
You don't want it.
but it's still current practice.
That's the
So it
problem.
seems to be, where do we, what decision are we really making here? I mean, to me, we're just frankly codifying current practice.
This doesn't need to be codified. I mean, I don't have an opinion. I mean, I do have an opinion, but I'm biased, so that's weird, right?
It's okay, as long as you're acknowledging your bias. What's your
Acknowledging my
opinion?
bias,
What's your opinion of?
but I don't get the conflict.
I think these are decisions that we have to weigh within
And think about
ourselves.
more testimony, or maybe there isn't any, maybe it's just we decide.
Is there any more is there anyone that you would like to hear from? Would you like to hear from the board again?
Well, I mean, I think the statement's clear. I think we need to hear from hospitals because
Yeah.
that's about current practice. I think that's the issue for me is that conflict between
Yeah.
current practice and the board, because we had OPR who supports it.
Yeah. And I will say that, the board said, that they support like with rigorous protocols and training and things like that. So, I mean, maybe we should hear more from the hospitals that actually are doing this, what their protocols are for, unless Devin can get it right off the tip of her.
I guess the struggle for me is if they're raising an issue for potential safety, what do we need to ensure for safety? And if the APRN process, we put that in the bill, or we just say we support hospital decision-making, or, whatever it is that we know that patients are going to be, that the safety is addressed.
We do have, I mean, currently in APRNs, after 3 years of supervised, may practice independently. So we have that's already.
It's a statute,
That's
right.
a statute.
The statute, just to
Yeah.
make sure that we are.
And we already have in statute that physician assistants must have a collaborative agreement.
But no specific hours or training.
Is it that they have to have,
So I want to stop on the APRN piece for a moment.
Yes, let's do
It's
that.
an APRN with fewer than 24 hours and 24 months and 2,400 hours of licensed active advanced nursing practice and an initial role in population focus, or fewer than 12 months and 1,600 hours for any additional role of population focus, has to have a formal agreement with a collaborating provider. And then I think once they satisfy those requirements, they are allowed to engage in solo practice.
Okay, so it would seem as
So
though
that
any provider
those numbers that the board is giving are the numbers for APRNs. To
Okay,
be clear, 2 years and 2,400 hours. And then an additional 12 months and 1,600 hours for additional role in population focus.
so if
Whatever
if
that.
an APRN is being employed currently in an inpatient setting, practicing on their own, they've met by virtue of their license, the 2,400 hours and 24 months of practice. Right?
Scope of practice, does that come into scope of practice? I guess it's just what OPR will license. They have done it, that they have documentation.
I have questions from Brian and Hopper.
It's not entirely clear just from the statute. The statute is on transition to practice. It's not entirely clear sort of what they have to file where and with whom, but I imagine the Board of nursing has a documentation process. And, right, we can
Yeah.
look at it.
Yeah.
Is there any similar provision around physician assistants that they have to have supervising for a certain number of hours? And they can be,
They are not permitted to practice without a collaborating physician agreement. So there is no transition to solo practice for physician assistants.
yeah, I guess what I mean is there a directly after licensure, is there a supervision and then they can go to a collaborative after so many hours? Or is it straight from?
Don't believe so. I don't think there's any kind of transitional, it just goes, they just have to have a practice agreement. They can only engage in practice in the state if they are in a practice agreement with a physician.
Okay. Brian, you have a question?
Comment question. The comment was that it goes back to the why do we need to codify something that's already happening? And I would say that sometimes it's good to codify the current practice because it eliminates any question about it and it creates a consistent framework for people to follow. My question would be, before we do that, just making sure that we're comfortable with, we meaning collectively we, like not just our committee, but like the people, whatever, are comfortable with the training and the protocols, et cetera, for having APPs doing the work of MDs or,
I think that's where the word surrogate came from, that I got stuck on with Dr. Greenberg. That the idea and why they're against it is that APPs are seen as surrogates for MD, for doctors. I mean, I was trying to figure out, he used that word and I was just trying to understand it. I think that's what I distilled it down to.
And I don't think of them so much as surrogates. It's just another component of the healthcare system that is highly trained.
Well, it's a surrogate because they don't have enough docs. So I think APPs have been needed in hospitals in order to function, right? And so that's good that they do that. But it's a need.
It's almost like the APPs have been used to fulfill a need that the MDs aren't available to fulfill. And whether it was approved or not, it's become the practice.
It's standard.
Yeah, and so,
And
yeah.
now the docs are against it. So that's what's very confusing. Can I have no tissues?
It doesn't confuse me only because historically, my experience with MDs is that they want to maintain the hierarchy of the system, and it's not like a personal thing. It has to do with training. It has to do with like all the training they go through. So there's concerns like, oh, we have to do all this training, and now people who are lesser trained are doing this thing. Is that going to undermine the system? So I get it, but the reality is the system's already functioning that way. So, and what are we going to do?
Yeah,
So-
so my, I guess what I'm struggling with is by this Board of Medicine statement. I'm sorry, I think I've been jumping all over people, but they're not acknowledging the reality of what's needed to do this work because that there aren't sufficient docs to do the work. So why not? It's confusing.
So I guess what I was going with it was maybe we need to hear from the hospitals or whoever what the trainings and protocols are to make sure that these providers are equipped to fulfill their duties. And if we can confirm that, either we pass this or we add something to this that requires that or whatever, but I don't think we can pull the rug out from under the current practice without there being consequences.
I don't think we should. I think
Yeah.
we have to support bias. I think we should support current practice because that's what needed to run the system.
One question that may be helpful to ask the hospital when you hear from them as well is whether they would expect to change their current protocols and requirements if you pass this legislation. It would be my expectation that they have put them in place because that's what they think is the most appropriate for the delivery of safe patient care in their facilities. But if there's something about this language that would change their requirements, you may want to know that before you pass the law.
Thank you for making the point. I wanted to make the point that hospitals would not be doing this if they felt it was unsafe.
Yeah.
Because don't forget, they have malpractice.
Yeah.
Yeah, they have a lot at stake.
Topper's been holding on to a question.
No, it's been discussed, but I was going to talk about, I'm not going to be here, so, but I would recommend,
Not bad.
I would recommend that you do just what Brian just said. You need to talk to the hospital. How do they do this to make sure that the patients are safe?
And also adding to that is the consequences of doing the APRNs and the PAs. You know, I think I heard there might have been a conflict there. Now, whether it was a pay issue or priority issue, but I think I remember hearing something about doing the both, or maybe it was a cost issue.
One of them doesn't get as much training as the other.
Well, I know, but
I think the bill was put forward by ATRNs. And as the bill evolved, I don't remember hearing any conflict between APRNs and PAs. I think it was just a matter of it was introduced because it was brought forward by APRN.
do we know if there might be some sort of a conflict?
I think we've gotten tons of APRN emails saying this would be great if you did PAs too. I don't think any PA of the.
No, I don't see a problem, but sometimes we pass things not knowing the consequences. That's why I brought it
I
up.
think the testimony that I heard you receive was largely, if you're going to do APRNs, there's no reason not to do, or you should do PAs. You know, you're hearing from the Board of Medical Practice, they'd rather you didn't do either, but I think even the chair of the board, and I think the testimony was, if you're going to do one of the advanced practice practitioners or providers, you should do both.
No reason not to do both.
Is this any extra cost to the hospitals?
This is current practice in.
Right, and I think maybe it's helpful to look at the language again, just to remember the context that this bill is in.
Yeah.
So the context that this bill is addressing is the Bill of Rights for hospital patients and rights that patients have in the hospital as far as having an attending provider who is responsible for coordinating their care, and who do you want to list as the types of providers they are entitled to have responsible for coordinating their care. Rights to obtain information about their diagnosis, prognosis, be able to provide informed consent. But basically knowing who the provider is, and getting complete information from the provider who is responsible for coordinating their care. And so I think the testimony that you've heard, and that was heard at least as far as APRNs downstairs, is that all three of these provider types, I think, are often filling this role. And the question is, do you reflect that in the statutory language providing rights? Similarly, in the hospital licensure statutes, the Department of Health can only issue a license when it determines that the applicant and hospital facilities meet certain standards. And the two relevant ones that currently mention physicians are that all patients admitted to the hospital shall be under the care of, and do you want it to be specifically a physician, which is current law, or do you want it to say, or can it say that all patients, that to be licensed, they can find that all patients admitted to the hospital are under the care of one of these provider types, and that one of these provider types is signing the professional case, the medical records for the patient.
Very helpful. Thank you. So I think what I'm hearing is that people would feel a little bit more comfortable if they heard from hospitals. Am I reading the room right, or am I? Okay. So that obviously isn't going to be today. Devin, do you think that you could, at the most earliest convenient, please have some hospital talk about and sort of what their protocols are, hiring, all of that. Go ahead. Frank.
Yeah, I just want to clarify that it's not that I'm not comfortable today because of anything except what we just heard from the Board of Medical Practice, that statement saying what they said in that statement, I would like to hear the hospitals respond to that statement and reassure us that doing this is the right thing to do still. That's all.
I agree. I think
Okay.
that's reasonable.
Yeah.
All right. So that whole possible vote, not gonna vote on this today. All right, Jen,
Yes.
let's do, moving on. S-189. We are gonna do a walkthrough of this bill.
And then we have a break, right?
We do have a break.
I'll try to hold on.
While Jen is pulling up this bill, I wanted to put something out there for the committee, which I don't think that I did, and I meant to do right after crossover. I've been struggling a little bit finding reporters of bills. And I think that we've had an uneven distribution of bills that have been reported. And I wanted to let the committee know that I'm going to be assigning reporters to bills, and it could be on any bill. And I wanted people to be aware that they could be called on at any time to report a bill.
Could I think about that for a minute, if I may? It would be great if you make a decision about that, but it would be really great to have it more upstream so that, because when you're a reporter, you might listen to things a little bit differently than if you're just, listening. So knowing as soon as possible.
I believe that my, the point is I'd like everybody to be thinking on every single bill as if they were reporting the bill. That's.
I'm gonna disagree with all that.
Okay.
Okay, and
First of all, if I don't believe in the bill and I don't vote for it, I won't report it.
I believe that I will be taking that into consideration. Does that mean that you're just gonna vote on it?
I will do it, but I will say up front, I do not support this bill I'm reporting.
Getting out of jury.
Should be.
The point is that we needed a more even distribution of
You could-
the labor in the committee, and that's all I'm trying to. 'Cause
if you get chosen to do a bill you don't believe
We're
in, you
all-
could come up with a very creative way to present it that would report the bill itself, matter of fact, but embed all these little comments in it that undermine the bill. So I mean, you could use that position. If you
I wouldn't do that.
Okay.
we're all elected, and it's imperative that we all pull the weight. And that is my point. Wait, why does the healthcare advocate want to weigh in on it?
Here's my turn. I like the shirt. I just want to say, Hudsonism. I remember him saying one time when he was reporting a bill, I didn't feel this way, bill, I'm just.
All right, Val?
Okay, moving on from that, Jen's now gonna walk us through 189.
Okay. So we are switching gears here to S-189 as passed by the Senate. And this is an act relating to establishing a process for reducing or eliminating hospital services. It creates a new section in Title 18.
I'm sorry, Jen, I thought you were asking for the donut. I'm sorry. He just doesn't care anymore. He just knows he'll never have to report any of these bills, so. Okay, go ahead.
There are more here.
Yes, everybody's got 189, let's go on, thank you.
S-189, an act relating to establishing a process for reducing or eliminating hospital services. It adds a new section in Title 18, but it actually also takes this language out of an existing section in Title 18 that was added last year in Act 68. So for those of you who were here last year, you may remember there was talk about creating some kind of a process when a hospital wanted to reduce or eliminate a service. And you put that in, or in between downstairs and up here, you put a process in for notice, and the Green Mountain Care Board could consider whether changes needed to be made to the budget of a hospital in light of a service reduction or elimination, and also just trying to make sure that people were not surprised, given some recent experiences where people had been surprised by a hospital service reduction. So this would require that a hospital that proposes to intentionally reduce or eliminate any service, and I'll pause for a minute on intentionally. This was a topic of discussion downstairs, but there were concerns about what would happen if a hospital had a provider leave and the provider was the department. And so at least for some time period, they're not able to offer that service, or maybe choose not to start offering that service again, but they're not intentionally reducing or eliminating the service based on a provider leaving, retiring, moving on. So this is a hospital that's making a choice, a hospital that is intentionally reducing or eliminating any service.
I mean, it's been a year. Didn't we deal with that whole situation in 26?
That's what I'm saying. This is undoing that and doing something different.
Oh, okay. So we're.
Yeah, so you'll see where that language is struck in the next section.
Worked so hard on something, and next year there's just a big line.
Yes, I would say you'll certainly want to take testimony on this, but I don't think all of the players in the process were happy with how it turned out.
Okay.
So the hospital that proposes to intentionally reduce or eliminate any service must provide a notice of intent to the Agency of Human Services, the Green Mountain Care Board, the Office of the Healthcare Advocate, and the members of the General Assembly who represent the hospital service area, not less than 60 days prior to the proposed reduction or elimination. The notice must explain the rationale for the proposed reduction or elimination and describe how it is consistent with the statewide healthcare delivery strategic plan once established, and the hospital's most recent community health needs assessment conducted pursuant to both state and federal law. And some of this language is similar to or identical to language in the existing process. It's just setting up a different process. So they must provide a notice of intent to various entities, including the local legislators. Post the notice of intent on the hospital's website beginning on or before the day on which they provide notice under subdivision 1. Publish the notice in a newspaper of general circulation in the hospital service area within 10 days after notice is provided pursuant to subdivision 1. There was some discussion downstairs about publishing in the newspaper being outdated, but we don't have a better mechanism yet, or at least a generally agreed upon mechanism. So that's what's in here now. You can certainly make changes.
A press release.
We can talk about alternatives. They must conduct a public engagement process, including holding one or more public hearings in the county in which the hospital is located and soliciting and responding to public comments regarding the proposed service reduction or elimination. The public engagement process may begin prior to providing the notice required in subdivision 1 and shall continue for not less than 30 days following the notice. The hospital shall provide a summary of the community's response to the proposal, including the public comments received, to the Agency of Human Services following the conclusion of the public engagement process. Then the Agency of Human Services must analyze each proposed service reduction or elimination for consistency with the statewide healthcare delivery strategic plan once established and the community health needs assessment. Consider the community's response and the impact of the proposal on access to necessary care and services in the hospital service area, and provide non-binding recommendations regarding the proposed reduction or elimination to the hospital, the Green Mountain Care Board, and the public.
Clarifying question.
Yes.
The statewide health delivery strategic plan, is there a goal when that will be done?
I believe the first iteration of that is due in January of 2028.
Okay,
That was from Act 68 of the same S126 last year.
so that's a while out there.
I think we're gonna get an update on that.
If a hospital elects to proceed with reducing or eliminating a service after completing the process in subsection A, then within 5 business days after making the decision to proceed, The hospital must notify the Agency of Human Services to inform the agency's healthcare system transformation efforts and future versions of the strategic plan, and the Green Mountain Care Board to enable the board to review the impact on the hospital's budget. In section 2, this is amending the board's hospital budget review statute. So this is striking the language that was added last year, directing the hospital that proposes to reduce or eliminate a service in order to comply with the budget order to provide a notice of intent within not less than 45 days. This bill would have 60 days. With the notice still explaining the rationale for the proposed reduction or elimination and describe how it is consistent with the statewide healthcare delivery strategic plan once established and the community health needs assessment. So some of these concepts have just moved over to the new statute. Under the current law that would be struck in this, the board may evaluate the proposed reduction or elimination for consistency with the strategic plan and community health needs assessment, and may modify the hospital's budget or take additional actions as the board deems appropriate to preserve access to necessary services. And then it had a carve out for services that had been identified for reduction or elimination as part of the transformation efforts with the board and AHS. Instead,
Daisy, do you have a question?
Which board are you talking about?
it's the Green Mountain Care Board. This is all, the whole section is all about Green Mountain Care Board. So instead, so that language is coming out, and instead, in addition to the new notice public engagement process and non-binding recommendation from the Agency of Human Services, upon receipt of notification from a hospital pursuant to the previous section that the hospital intends to reduce or eliminate a service following its completion of that public engagement process, the board shall review the impact of the reduction or elimination on the hospital's approved budget. And this would allow the board still to adjust the hospital's budget as necessary to reflect the elimination or reduction, which may include directing that any savings related to the reduction or elimination are returned to Vermonters to address affordability concerns, or to payers to be reflected in health insurance premiums, or are reinvested in primary care, prevention, and other community-based services. And then the language, we would keep the language directing the board in collaboration with the Department of Financial Regulation to monitor implementation of any authorized reduction or elimination of hospital services to determine its benefits to Vermonters or the healthcare system, or both. And it would take effect on passage. So as I mentioned at the outset, this is looking to kind of revise the process set up last year that has not been workable for all of the parties involved. I will invite you to hear from them.
I don't, if people followed multiple different hospital service line reductions throughout the past year, it would probably, there were some very public ones. Yeah, and then Leslie.
Well, I'm just curious. I don't even know how to word this question. Would hospitals ever already spend this money and then just kind of, how do hospitals use their money? I mean, do they, I know they have like cash on hand as a bank, but is there any way a hospital would get in a really bad spot because they may have already used this money and then have to come, does that make any sense?
I think that would sort of be more in the Green Mountain Care Board's hospital budget review process that you're thinking of. Here, I'll give a couple examples of what this bill is sort of addressing. There was there was a budget enforcement for UVM Medical Center. I think it was UVMMC. And they cut several service lines. They cut some primary care in central Vermont, closed a practice. They cut 8 inpatient beds, was it?
Psych beds.
Psych beds at Central Vermont Medical Center. We heard earlier today from the dean, they cut transplant. I'm trying to think of the word. I'm like, when is it when you take an organ and from one and put it somewhere else? They cut their transplant services, so they did all these service line reductions. And I don't know if you followed, there was a lot of uproar about that, within the public, and, then we did this bill last year, that essentially said before you can just summarily cut services, you have to sort of have approval for it. And then this summer, you might know, there was the situation with Rutland Regional, who had proposed eliminating some of their inpatient pediatric beds. And that went through a process. And this is actually sort of how I will this is kind of why this bill is before us, because there's not really a statewide plan as of yet. And we're in this interim period before the statewide plan is implemented or imposed, presented. And everybody sort of felt a little hamstrung around how do we decide if this is yes or no when we're not really dealing with anything. So this bill is to try to address that sort of thing.
So if someone said, okay, I want to retire, and you have to give 60 days.
So that's why it says intentionally reduce, because if somebody's going to retire, that's not the hospital choosing to reduce a service. That's sort of happening to the hospitals.
Right. So would they already have a fixed amount in the hospital for that service that's going to get yanked back, but maybe they already used that money as much?
I think that would be part of their modification of a budget order with the Green Mountain Care Board, I think, but I would like the hospital.
They'll take a lot of testimony on this. We'll hear from the board, and I think they'll be able to answer that question if you just asked. So we'll just kind of a little background on the language. Do you have any other questions about it? On the language, Leslie, did you want to?
So, I know this is focused on hospitals, but in my community, what was withdrawn was primary care. That was provided by an FQHC. There was enormous community uproar and no response whatsoever from the FQHC or the hospital service area people. So my question is there a way to think about this beyond hospitals when there's service line reductions by other healthcare providers, or is that too confusing to the topic? And I would get that, but I would like to see how we can protect communities through that way as well.
I think we regulate hospitals. We don't regulate FQHC.
Yeah, on that note, it says hospital, but it doesn't say health systems.
Yeah. And what do you mean because you say the Green Mountain Care Board regulates the hospitals? That's what you mean?
And they do regulate the health systems. So that's why I'm wondering if
I think it
it's.
depends what you mean by health system.
You're talking about like networks?
Yeah.
Which are not called networks anymore.
Yeah, exactly. Like, for example, the university, UVM Health is a hospital, it's a network of hospital and health facilities, and they are regulated by, right?
No, they're not.
You put some provisions in around them last year.
I thought we did with that hospital bill.
But we put in reporting around them, but not regulation of them. I think we have to regulate them through the hospital.
Right, you largely regulate them through the hospitals, but you did put some language, I think, in around budget, looking at their budgets.
I guess the reason I brought it up is because Leslie's concern about this healthcare system in general and service reductions at different points in the system, that we might be able to monitor or mitigate it or whatever the word is through the hospitals, through the health systems of hospitals a little bit, but.
I was very frustrated, I'll just say, because I was really trying hard to get this addressed in my community through HS, and there's like no response whatsoever. And that was a real loss to, and it's a rural poor community.
I will also point out that every year for the last few years, we've put money in the budget to include this year for provider stabilization grants. Karen?
This is just a concrete example that might illustrate the problem. I think Waitsfield had a primary care place affiliated with UVM, and it was closed, sort of similar to those beds in where would there be any oversight or?
My understanding that this would be included in that because it is a service provided by.
When I said they closed the primary care practice, I was referring to Waitsfield. Okay.
So then the distinction would be made if you're owned by a hospital or not owned by a hospital. In the community, it's regulated by the hospital. Well, regulated, yeah.
And your budgets are regulated. Tupper.
Jen, is the published rationale for using the term may as opposed
Here.
to shall on page 4 down the bottom of the page. Talks about if the hospital decides to reduce 8 beds, then the Green Mountain Care Board may adjust for hospital budgets, or they may include directing them to do certain things. Why was it may instead of shall?
I mean, my understanding generally was to give the board authority, but not require them to, depending on the scope of the reduction or the hospital's proposed use of any savings that may not be necessary or appropriate to adjust their budget. Maybe something that, they deal with in conversations with the hospital, but doesn't require an official adjustment to the hospital budget order. But I don't know that there was much discussion about should that be a shall or a may.
Because you got a big problem. The Central Vermont closing those beds was huge. And
So you may want to hear from the board about, I think generally, we talked the other day about concerns about, that was not this committee. We talked in another committee about, but about the extent to which you allow the regulator to make their own decisions versus directing them in how they do or do not take actions.
I suspect we're gonna hear.
This is providing authority, but not directing action.
All right. Thank you, Jen. Thanks so much. So we're gonna take a break. How about we come back here in 15 minutes at 11:20. I'm gonna do math in my head.
it's
11:20.
only 10 minutes.
According to the clocks, which are now different again,
It's actually 11:06.
the clocks are, every clock in this room says something